Good morning. This is Group B. I'm James Bartalotta. Here we also have Celine Soon, Jordan Sparks, and Krystine Habel. Being tasked with presenting this pain case about our patient Yvette B, who is a 29-year-old female and has come into our clinic with a principal complaint of pain on the left side of her face, which had initially presented 9 months prior to her consultation. She has stated that she does not experience headaches or earaches. However, she has been experiencing difficulty in chewing and a sharp pain whilst eating and talking. Yvette also claims that she has been experiencing a constant dull ache in her left jaw in the absence of any function or movement. Now, upon admission into the consultation room, Yvette's medical history was taken, and it was found that she suffers from asthma, but has not stated whether she takes any medication for this condition, or to the severity of her asthma. It is also noted that she is currently taking citalopram, which, upon further research, was found that it is an antidepressant medication that is in a class of antidepressant drugs known as selective serotonin reuptake inhibitors, or SSRIs. Now, as a result of our patient being on this medication, we should keep in mind some of its adverse side effects, such as xerostomia, which is a major concern in terms of dental and oral health. Additionally, the presentation of erythema migrans, or as it is more commonly known, geographic tongue, which was discovered during her intraoral examination on the dorsum of her tongue, is known to be exacerbated in times of psychological stress. Now, it's implicated that she may be experiencing such stress, seeing as she is taking these antidepressant medications. Another thing we must also be cautious about with patients on citalopram is its effect of causing postural hypertension in some cases. Consequently, we should take extra care when assisting Yvette in and out of the dental chair, as sudden changes in posture from lying down to standing up may induce fainting. Furthermore, we must consider the interactions of citalopram with drugs that we may prescribe to her for her treatment of the facial pain. Krystine will discuss this in more detail later on in the presentation. Now, it's also noted that Yvette occasionally drinks alcohol, so it is our responsibility to discuss with her the possible implication of alcohol consumption on her oral health and its interactions with her antidepressant medication. During the extra-oral examination, her level of mouth opening was assessed and was determined to be 2.5 fingers wide, which is within the normal range of mouth opening, 2 to 3 fingers. This suggests that there are no restrictions on the opening of her mouth. However, there is tenderness in the muscles when they were palpated. Furthermore, an assessment of her salivary glands revealed no abnormalities, as they were soft to touch. From the dental examination, it was evident that Yvette is a bruxist. Now, this could implicate the pain she is suffering from in her masseter and pterygoid muscles due to their overuse and parafunction. As you can see in this slide, it indicated that Yvette feels a 7 out of 10 pain on the internal pterygoid muscle on the left side, and a 7 out of 10 pain on the internal masseter muscle on the left side, with a slightly less 4 out of 10 pain on the right side. Now, the effects of bruxism on the teeth are obvious on the radiograph presented, and I'll pass on to Jordan, who will now discuss the findings from this radiograph a bit further.
Thank you, James. So as we can see, Yvette has undergone an OPG of the maxillofacial region. Starting outside, we can see no bony lesions in either the maxilla or mandible, and the maxillary sinuses look fine. While the left condyle appears to be posterior and superior, which may affect Yvette's centric relation, further scans are needed for analysis of this highly complex joint. As the X-ray beam is directed from an upward position under the joint during panoramic films, The lateral extremity of the condyle is projected upwards, and thus details concerning the joint are lost due to being superimposed over bony landmarks. The condyle does not appear to be sitting sufficiently in the glenoid fossa, and asymmetry from left to right may indicate a problem with the TMJ. Further assessments, such as physical examination of the TMJ and ultrasound to obtain a better view of the TMJ while opening and closing, and other means such as tomography, are needed to conclude a definitive diagnosis concerning the TMJ. Furthermore, the midlines of the maxilla and mandible appear to be off-centered, which may influence the positioning of her condyles in the glenoid fossa during occlusion. So dentally, we can see that Yvette has her complete adult dentition present from 7 to 7 in the maxilla and 7 to 7 within the mandible. Her canines in both upper and lower incisors appear flattened or ground down, which supports parafunctional habits. However, well-shaped anatomy of molar cusps indicates further analysis is required. Additional investigation is required to assess heavy or premature occlusal interferences, which may be causing deviation of the condyles in the glenoid fossa. Both the 1-3 and 4-3 appear to be rotated. The 2-1 appears to have minor restorations on both the mesial and distal, and mesial radiopacities on the 2-2 indicate a mesial restoration. Bone levels appear relatively normal, with minimal bone loss upon sexton 5 and absence of any apical pathosis. Slide overcrowding evident among sextons 1 and 6. 4-4 may be lingual or buccally placed, as indicated by the overlapping of the distals, and 3-4 appears to be infraoccluded. Potential mesial interproximal care is present on the 3-7, however further investigation by means of such a bite wings radiograph is necessary. I'll now pass on to Celine, who will discuss the...
Thanks, Jordan. The symptoms that the patient has presented with have more than one likely diagnosis. Therefore, for her differential diagnosis, we have proposed pain resulting from bruxism, TMD, which is short for temporomandibular dysfunction, and myofascial pain syndrome. Bruxism is a parafunctional habit with multifactorial etiology. With the limited information given, we have narrowed down etiology to depression, stress, and anxiety. Since the patient is on the antidepressant citalopram, bruxism may be a secondary adverse effect of the medication. To confirm this, more information regarding when she started taking citalopram will be needed. It will then be possible to establish any correlation between the medication and bruxism. TMD covers pain and dysfunction of the muscles of mastication. This patient has experienced pain at the masseter and pterygoid muscles, with more severe pain on the left side. The cause of this could vary and range from one-sided bruxism during the night to the occlusal forces being stronger on the left side. From the OPG, the left canine seems to be more worn down compared to the right. Furthermore, as Jordan mentioned, the mandibular midline is deviated to the right, which may result in more stress on the left side of the muscles and teeth. Bruxism could be the chief cause of the TMD. However, other causes such as an injury to the jaw, TMJ, or muscles of head and neck could also lead to pain at the TMJ. Stress is also a cause of TMD, as individuals tend to tighten facial and jaw muscles or clench the teeth under pressure. The dislocation of the articulating disc or the presence of osteoarthritis or rheumatoid arthritis are also possible causes of the TMD. However, to confirm the root of the problem, further information is required from the patient, such as potential psychosocial stresses, duration of the pain, time of onset, the type and severity of the pain, etc. Since the patient has experienced a constant dull ache for 9 months, the pain is no longer acute but is currently in a chronic state. Myofascial pain dysfunction is defined as pain arising from the relating muscles of fascia at the TMJ due to various causes of increased muscle tension and spasm. Symptoms include bruxism, pain and tenderness in and around the masticatory areas, or pain referred to other locations in the head and neck, and often abnormalities of jaw mobility. It is believed that MPD syndrome is a physical manifestation of psychological stress. No primary disorder of the joint itself is present. Pain is secondary to events such as nocturnal jaw clenching and teeth grinding. I will now pass you to Krystine, who will discuss management for this patient.
Thank you, Celine. Now with management plan. Erythema migraines is caused by is unknown but may be family history. Most patients have no symptoms, but some complain of soreness. Treatment is to reassure the patient. Anti-inflammatory such as Deflam mouthwash 15 ml for 30 seconds every 1.5 to 3 hours, maximum 7 days. Also, diet modification to avoid spicy foods. Bruxism, TMD and myofascial pain. TMD and associated disorders of bruxism and myofascial pain share common conservative and medication treatment options to manage pain. Further investigation is required to prevent misdiagnosis. Past medication, such as muscle inflammation, has been associated with SSRIs. Investigate joint noises, limiting movements, altered sensation, cognitive losses such as depression and emotional changes, sleep disturbances, previous treatments, parafunctional habits such as bruxism onset, trigger point of pain. Nature of pain, constant episodic radiating patterns, precipitating factors, relieving factors such as around the neck, back, shoulders and mandibular movements. Further investigation into intraoral include oral occlusal wear, missing teeth restoration state and periodontal disease. Laboratory investigation for metabolic and immune disorders. Radiographic investigation for MRIs for temporomandibular joint and ultrasound for soft tissue lesions. Aim is to control symptoms of underlying cause and eliminate contributing factors for the treatment. Conservative treatment is always the first line. Educate the patient about physical and psychosocial factors, stress management, diet to minimize chewing, extreme movements, Botox injections, trigger point injection, physiotherapy and massage, exercises, ultrasounds, splint dental guards require careful fitting and monitoring for several months to protect the teeth, reduce pain and load on temporomandibular joints, may reduce subconscious clenching forces, anterior reposition appliances to gradually return mandibular to its anatomical position, may require 24-hour wear or may be only required during nocturnal wear. Assess 2 to 4 weeks. Medications. They are used for short term, 2 to 4 weeks, including paracetamol 500 milligrams to 1,000 milligrams every 4 to 6 hours as needed, maximum 4,000 milligrams per day. NSAIDs may be contradicted in this case because patient has asthma. Aspirin, for example, 600 milligrams to 900 milligrams every 4 hours. Muscle relaxants such as methocarbamol, 1,500 milligrams 4 times a day for first 48 to 72 hours, maximum 8 grams per day. Anxiolytics such as diazepam, 5 to 40 milligrams daily. Corticosteroids, prednisone, 5 to 60 milligrams per day, 1 to 4 times per day. Patient is already on citalopram and occasionally drinks alcohol. This can increase the levels of drowsiness, confusion, dizziness, and with the above medications. So the patient needs to be told about this. Monoamine oxidase inhibitors should not be used with SSRIs, as there is a risk of serotonin syndrome of coma and death. Monoamine oxidase inhibitors have been associated with muscle spasm. NSAID used with citalopram may increase bleeding. Other consultation referral may be indicated. on review may require further investigation and treatment. Aggressive therapy does not guarantee relief from symptoms, but aggressive therapy includes bite adjustments, orthodontic work, orthodontics, surgery. In conclusion, disorders associated with temporomandibular joints are often misdiagnosed or underdiagnosed, so further investigation is required to obtain a definitive diagnosis and to complete a more comprehensive treatment plan for Yvette. Thank you.
Thank you.